I was going to say good morning, but good afternoon. It's great to be here. Thank you so much for inviting me to give this presentation. I'm going to discuss pregnancy and delivery in patients who have HHT. And this, most of my talk is actually based on the guidelines that were published, I guess, 3 years ago now. And the guidelines were created, as you know, by our lead author, Dr. Marie Fawnin, basically there was a million people involved, and Dr. Marie Fawnin organized everything for us, and she did an excellent job. Prior to the meeting, we reviewed all of the research papers, and we asked 6 key questions about pregnancy and delivery. And we all got together and came up with consensus statements. Unfortunately, as you all know, that there's not a lot of randomized control trials. They don't really exist in HHT. However, we came up with the best evidence that we could. So for pregnancy, we covered 6 topics. We looked at preconception and prenatal genetic diagnostic options. We looked at symptomatic brain vascular malformations, and then non-high-risk brain vascular malformations and mode of delivery. We talked about pulmonary AVM screening, reasons to go to a tertiary care center for follow-up, and then very importantly, epidural and screening for spinal vascular malformations. So since these guidelines were published, there was another publication, and this looked at HHT-related epistaxis and pregnancy. So I'm going to present this paper as well, because it's one of the topics that we didn't cover in our guidelines, and it's very important to know through pregnancy. So the first discussion point really is prenatal genetic diagnostic options. So as you know, HHT is an autosomal dominant condition, so 50% of children will inherit the gene, and 90% of families will carry one of the 3 following mutations, which we can definitely screen for. We know that pregnant people with HHT are not at higher risk of miscarriage than the general population. So it's important, if you can, to be able to have a pre-pregnancy consult with an obstetrician. So, and this would be, really beneficial for an obstetrician who has taken care of patients with HHT in the past. Basically, what we would do is review your current health and HHT status and how this may relate to risks in pregnancy, and then how to optimize your health prior to the pregnancy, and then give you some ideas about genetic diagnosis. So in today's era of IVF, we can think about things like pre-implantation genetic diagnosis, and then post-conception ones. So once you're actually pregnant, and then after delivery, once the baby is born. So what is pre-implantation genetic diagnosis? This is, incredible field, and it's growing so rapidly. But basically, when we look at genetics, it would be, and preconception, this would be carried out on an IVF conceived embryo. So basically, we would have to know exactly what we're looking for. So we'd have to know what the exact mutation was, and then we can screen an embryo to see whether or not there's a mutation that's carried there. And then once they're screened, you can have the option to transfer a non-affected embryo. Post-conception, so once you're pregnant, the options for genetic diagnosis would be something called chorionic villus sampling. So this is basically done early on in pregnancy, at the end of the first trimester, and we basically take a biopsy of the placenta. There is a risk of miscarriage though with this, and that's about 1%. And so we don't take these things lightly to go through these procedures in pregnancy. If you wait later on in the pregnancy, so after about 16 weeks, we can do an amniocentesis. So we basically take a needle, put it into the uterus, take some fluid from around the baby, and then we test for genetics. And this has a risk of miscarriage of less than 0.5%. So given that there are procedural risks, one has to kind of look at the question, what would I do with the results? So, if this is something that you want to screen for and would act on, so for example, consideration of termination of pregnancy, et cetera, then you may consider this type of option. But if that's not a consideration, then we would reserve these types of invasive procedures for other things. So, for example, there may be an anomaly that we see on ultrasound with the anatomy of the baby, or for example, you may have genetic testing and have screen positive results, for example, for something like Down syndrome. So we could reserve these types of procedures for that. And then after delivery, we offer every parent the option of genetic testing on the cord blood. And if you can choose to do that for your baby, or you can choose to wait. And if you choose not to do it for your baby, we basically would consider all children affected, so that they're screened appropriately. And then if you choose to go ahead with the genetic diagnosis, that can be done later as well. And that would be done via blood test on the child. So basically what we discussed as the expert panel, we recommended that clinicians would discuss preconception and prenatal diagnostic options, including pre-implantation genetic diagnosis in individuals affected with HHT. So moving on, we looked at pregnant people with symptoms of brain vascular malformations, and should they be tested with an unenhanced MRI. So pregnant people with HHT who have no symptoms of brain AVMs, we don't routinely screen for brain AVMs in the general population, and therefore asymptomatic patients don't require routine screening during the pregnancy. So if it's something that you come to see your doctor for, we wouldn't necessarily go ahead if you had no symptoms to do any type of screening. There's really not a lot of data, and there's not a lot of evidence about the specific risk of brain AVM bleeding in pregnant women with HHT. And there's no conclusive evidence of an increased risk of first bleed from a brain AVM during the pregnancy. So about 10% of women with HHT will present with asymptomatic brain AVMs. And if you have a known asymptomatic brain AVM, most of the time we would consider just conservative management, so not necessarily treating through the pregnancy. And if you have no symptoms and develop no symptoms in pregnancy, then we can treat the brain AVM after the pregnancy. And that's because of the low risk of bleeding through the pregnancy. However, if you have symptoms of brain AVMs, then we can proceed to do an MRI. Unfortunately, we can't use gadolinium in pregnancy, so we can plan to do the MRI. We can really do it at any stage in the pregnancy, but if you're having symptoms, then we would basically do it once you present with symptoms, or we can do it as a planned screen in the second trimester. And the annual risk of the first brain bleed in brain AVMs in people with HHT is about 0.41 to 1%. So it's really quite lower than the 2 to 4% risk for any sporadic brain AVM in people who don't have HHT. And 0.5% of unscreened women will present with a brain bleed during pregnancy or in the postpartum period. And we know this from a study that we did at our center in 2014. And in cases of prior bleeding of brain AVMs, the risk of rebleeding is increased, and this can be up to 30%. And it's mainly in the second and third trimester and the postpartum period. So our expert panel recommended testing with unenhanced MRI in pregnant women with symptoms that suggest brain vascular malformations. So what about people who have a non-high risk brain vascular malformations? Can they labor and proceed with vaginal delivery? So this was always a big question, and something that we really wanted to answer with these guidelines. So there's really no reports of pregnant people with HHT having a brain AVM bleed during labor. And even symptomatic patients, it's definitely important to review with a multidisciplinary neurovascular team. So this is really, done on a case-by-case basis. So essentially what we'll try to do is, if the neurosurgeon and team think that you can proceed with a vaginal delivery, then we would hope to have an effective epidural. And what we would do is allow for the baby to descend quite low into the pelvis. And sometimes, in order to avoid pushing, we might use something like a vacuum or forceps that may help expedite the delivery, so we don't increase the pressure in the brain. Sometimes, though, upon review, we look at the multidisciplinary team and then we think about proceeding with the cesarean section. So again, this is really case-by-case basis, and it really depends on what's happening with you and what happens during the pregnancy as well. So basically, our panel did recommend that women with a known non-high-risk brain vascular malformation can labor and proceed with a vaginal delivery. We may require what's called an assisted second stage, so basically forceps or vacuum, and you may need a cesarean section, but that's really on a case-by-case basis. Okay, and then what about people who have not been recently screened for pulmonary AVMs, and how should they be screened or treated through the pregnancy? So it's important really to review what are the changes associated with pregnancy. So what are the physiologic changes? So there's a big increase in cardiac output of about 30 to 50%. And that effect really is at its peak by around 20 weeks, so halfway through the pregnancy. There is an increase in blood volume of about 40%, and that peaks at about 28 weeks. And pregnancy also results in the very high progesterone levels, and this can make the veins very stretchy. So this combination of the fact that there is more blood volume, the heart is beating faster, there's a more cardiac output, this is what we call a hyperdynamic state. So there's lots going on to support the developing pregnancy. And with the fact that progesterone causes the veins to be more distensible, this may lead to rupture of pulmonary AVMs during the pregnancy. So this is something that we really have to think about through pregnancy and treat if we know that they're present. So we know that complications of pulmonary AVMs can occur at any time during the pregnancy, and about 85 to 90% of these complications can occur in the second or third trimesters. So we want to screen and treat as early as possible. So we really think about by around 12 weeks, if you haven't had screening, or if we know that there's something there, then we want to go ahead and try to treat. And so patients who've had prior negative pulmonary AVM screening, you may not see in the absence of symptoms, but there is a possibility of developing pulmonary AVMs, or there's a possibility that we may see them again because of these changes through pregnancy. So we may consider doing some tests for that. So what is the risk of a pulmonary AVM? So pulmonary AVMs in pregnancy can be very catastrophic. So you can, they can rupture, you can bleed, there can be blood in the chest, can lead to stroke, and you may get, you may get a paradoxical embolus. So when we looked at these earlier studies, they estimated the pre-pregnancy complication rate of about 35% and mortality for about 9%. So that's very high. And even in our studies later on, there is a mortality rate from complications of pulmonary AVM. So it's definitely something that we want to treat even through a pregnancy. So the way that we would screen for this is really to go ahead with the CT chest. And that's because about 50% of these bubble echo tests are positive, and then that would lead to a CT chest. So people may be concerned about having a chest CT through pregnancy and concerned about radiation. But we know that we can use radiation safely in pregnancy. Definitely, we would shield the pregnant abdomen, but even with that, the amount of radiation that you get from a CT chest is much lower than the amount that would potentially harm a developing fetus. So it is really important to go ahead to do the CT chest through the pregnancy. And then we want to think about treating. So it's, again, because we don't have tons of data, we have to expand the literature that we do have on pulmonary AVMs. And so we have to actually think about risk stratification. We're going to say presumably that larger pulmonary AVMs would be at higher risk, but this is not really proven. And then we think about what size are we actually going to treat. So we look at the size of the feeding arteries and decide whether or not we should treat them or not. So we think that pulmonary AVMs with a feeding artery of greater than 3 millimeters should definitely be treated. And if you have multiple pulmonary AVMs, then we should treat all of them at the time, try to treat as many as possible at the time. And if you've had previously treated pulmonary AVMs, the risk of complications through the pregnancy isn't precisely known, but can be approximately 5%. So it's still possible to have a complication with a treated AVM. And there is some procedural risks with embolization. However, it's definitely, the risks are lower than the risk of untreated pulmonary AVM. So basically what our panel recommended was that in pregnant women with HHT who've not been recently screened or treated, we should go ahead and screen them with a CT chest. And if we are concerned about a pulmonary AVM, then we should definitely go ahead and treat them through the pregnancy. So many people will ask about whether or not pregnant people with HHT should be followed in a tertiary care center. So, if you're living in the middle of the heart of Toronto, that's very straightforward. But, most people are not living here, and most people are living out perhaps in more rural areas, et cetera. And do you need to come all the way down to a tertiary care center to be followed through your pregnancy? So is this considered a high-risk pregnancy? So the label of high-risk pregnancy is used to describe situations in which the pregnant person and the fetus are at higher risk of complications during the pregnancy, labor, delivery, or postpartum when we compare them to a typical pregnancy. And most pregnant people with HHT are labeled high risk, but that's not necessarily the case for the individual person because you may not be at higher risk of developing complications through the pregnancy. So basically what we need to do is if you've just been diagnosed with HHT and you've had your screening and you're negative for vascular malformations, then it's most likely that you will have a typical pregnancy. And many pregnant people with HHT are initially seen in a high-risk center. And then when they're reviewed, we say, okay, things are fine. You can go back to your local center. And we may give some recommendations to your obstetrician, but you don't necessarily have to come to a tertiary care center. When you're assessed at a tertiary care center, though, you're assessed by a whole team of people. So obstetricians, maternal-fetal medicine specialists, respirologists, and anesthetists, and then anybody who would need to potentially get involved if there are vascular malformations that potentially need to be treated. And people with minimal disease, so if we know that you don't have any vascular malformations, then you can be managed at a tertiary care center if you're close by, but that's not necessarily, that doesn't have to be the case. So again, we can give recommendations to physicians who are taking care of you at outside centers, and you can proceed to deliver there. And then in terms of recommendation for a place of delivery, again, that's on a case-by-case basis. Sometimes people are seen by a routine obstetrician, out in the community, and then may choose to deliver at a tertiary care center. So that's definitely something that can be considered as well. So we want to think about risk stratification. So in terms of risk, we look at the sort of overall risk of about 1% of complications in pregnancy in patients with HHT. But this is really based on the results of screening for any vascular malformations. So the highest risk person is going to be somebody who is unscreened. And we don't know what's actually going on, what your potential risk could be. And then if the next person would be somebody who's screened and we know that there's some, for example, pulmonary vascular malformations that are not treated. And then, again, so once people are starting to get treated, then the risk really decreases. And certainly if there's no vascular malformations that we need to be concerned about, then the risk is low. So basically, what we're recommending is that pregnant women with HHT be managed at a tertiary care center by a multidisciplinary team, especially if they have untreated pulmonary VMs or brain VMs, or they haven't been recently screened. Okay, so what about an epidural? So this has really sort of always been a contentious issue, and pregnant people, will with HHT will come to me and say, oh my gosh, can I have an epidural? And this is something that we really wanted to address in these guidelines because I think a lot of women have been denied an epidural because of the fear of these spinal vascular malformations. So we know that they can exist in people with HHT, but they're very rare. And the incidence of symptomatic spinal vascular malformations is about 0.5%. They're mostly in the pediatric population and predominantly male. And most of the time, the spinal vascular malformations are actually quite high in the spine, so around the level of the thorax. So an epidural is given much lower than that. So the chance of complication is very, very low. So when we look at where the epidural actually goes, it doesn't go anywhere near the spine. It actually goes into what's called the epidural space. So the spine is up here and then the nerves will come down. And it depends on the location of where actually these vascular malformations may be. And they're usually up higher around the actual spine, so nowhere near where the epidural would go. And so when we looked at the large studies that we have of pregnant people with HHT, there were no reported complications of epidural or spinal anesthesia. And we looked at 185 deliveries in 2014 and 484 in 2008. And there was no incidence of spinal hemorrhage. And there really aren't any case reports either. So there's only a few case reports in non-HHT patients who develop post-epidural spinal complications, but the complications were always treatable. So when we review this kind of literature in terms of screening, we think about doing an unenhanced MRI, and it only excludes medium or large spinal vascular malformations. We can't use gadolinium in pregnancy, and the location doesn't really influence the risk of rupture or the theoretical risk of epidural anesthesia. So although we don't recommend screening, it's still prudent to have the epidural or spinal performed by an experienced anesthetist. And pregnancy, we know, may exacerbate the symptoms of a spinal vascular malformation if you have one. And definitely, if you know you have one, then that's something to be discussed with an anesthetist. And again, will be looked at a case-by-case basis. So I think this is a really important take-home message, is that we recommended not withholding an epidural because of a diagnosis of HHT, and that screening for spinal vascular malformations is not required. Okay, so the last thing that I wanted to just talk about, because it was recently published, is looking at epistaxis or nosebleeds and pregnancy. And we know that pregnancy definitely increases risk of nosebleeds in anybody. I see lots and lots of patients who come in who've never had a nosebleed before and all of a sudden started having nosebleeds in pregnancy, and it's a really, really common thing. So this study, again, is retrospective like most of the other ones. There was only 46 patients, and basically these patients were given a questionnaire and then asked to answer questions about pregnancy, and it was a long time ago for a lot of these people because the median age was about 60 years. So 84% of people who had responded had actually completed their childbearing prior to the diagnosis of HHT. So that means that they didn't know that they had HHT while they were having nosebleeds in pregnancy. And interestingly, actually, in terms of people who did report having nosebleeds, about 61% had them. 46% said they were about similar to this when they were not pregnant. Only 27% had an increase in nosebleeds in pregnancy, and 27% had a decrease in nosebleeds in pregnancy. So that was actually fairly interesting. It seems here that pregnancy really didn't, increase it that dramatically. 71% didn't need treatment, and 75% of people who needed treatment were able to self-treat. And then of the very small number that actually needed a medical treatment, they had some combination of cautery, laser, or packing. So basically, this paper was great because it also gave some guidance for what should happen sort of prior to pregnancy and during the pregnancy. They did reference the guidelines that I had discussed in terms of this, seeing different specialists, et cetera. And really prior to pregnancy, talking about nasal care, teaching people how to do self-packing, et cetera. And then the same thing can occur during the pregnancy. And then if you need to be treated, then you could definitely go ahead and do through pregnancy as well. And they also didn't find that there was any increase at the time of delivery of nosebleeds through the pregnancy. So through our website, there is now a tab on pregnancy and HHT. And I think this was one of the things that I was really happy that got published and is accessible to everybody. This is something that you can print off, bring to your doctor, and then go through all of the different points. So thinking about planning a pregnancy, what will happen if you have any vascular malformations that we need to think about, and then during the pregnancy, where you should be taking, who should take care of you through that pregnancy. And then this is just, a copy of what we've gone through here. So this basically concludes my presentation, and I'd be happy to take any questions.
Dr. Lausman, thank you so much for your presentation. I'll be reading out some of the questions we've received. and I'll keep reading them out as they come. The first question we have, are there any diet or lifestyle factors that can incur HHT-related risks to the fetus?
So no, so that's a great question. So basically, we know that the fetus has, as I said, a 50% chance of getting the HHT gene. So, and there's nothing that you can do to prevent the inheritance or to sort of make it better. So unfortunately, there's no lifestyle changes. No.
Our second question, is there a risk of false positive testing when we are doing child genetic testing, considering that there may be mixing of the blood from the mother?
So the blood and the baby's blood and the mother's blood don't actually mix. So when we look at genetic testing, so sorry, was it about the child, like at the time of birth? That was the question?
I think they were referring when we are doing the genetic testing. If
Okay.
the method by which they do genetic testing, there might be a chance of false positives because the blood might mix.
Yeah, so the baby's and mother's blood don't mix at any point. And basically, when we're looking at the genetics, if we look at the preconception, we're just looking at the embryo. If we're doing an amniocentesis or a CVS, we're looking specifically at the genetics of the fetus. And then after delivery, taking the cord blood, it doesn't mix with the mother's blood. So there isn't that possibility.
Thank you. So the next question says, there are some drugs that are counterdicted in pregnancy. Is this list any different in pregnant individuals with HHT? Or in other words, can any drugs increase the risk to the mom or the child?
So I'm not sure if you're asking about drugs that may be used that you're taking after having a diagnosis of HHT, but we know that there's many drugs in pregnancy that are very safe. And I think because there wasn't a specific drug, specified here, I would suggest going and speaking to your doctor, making sure that you're list the drugs that you're taking. But most of the drugs that people will be taking would be safe in pregnancy. And lots of times, if they're not, there's another option that can be safe in pregnancy.
I see. Is it possible to develop uterine AVMs? If so, does the risk increase in pregnancy?
Very good question. So we actually gave a talk with one of the gynecologists. So there really hasn't been a lot of data on uterine AVM. So it is possible. I mean, it is a possibility. It's not something that's really been reported in the literature very much. It wouldn't really be something that would develop through the pregnancy, though. So and it's not something, again, that we would screen for. So for example, sometimes if people are having issues with fertility, likely unrelated to HHT diagnosis, they would have all sorts of different kinds of tests, including an ultrasound of the pelvis and looking at the uterus, looking at the inside of the uterus. And uterine AVMs are quite rare. So that's why they haven't really this is a rare disease, and for them to be reported in HHT was exceedingly uncommon. So I would say it's not something that you need to be concerned about, and it wouldn't develop after a pregnancy had implanted.
Thank you. Does having HHT increase the chances of the fetus having other genetic abnormalities?
So no, just because, so it's, so the genetics will be inherited, chromosomes from the father and chromosomes from the mother. And then, it depends on whatever the genetics are of the parents. So for example, if there are other genetic diseases that will run through the family, then, there is a possibility of that inheritance, but just carrying the HHT gene doesn't put you at increased risk of other genetic problems.
Thank you. Is the mother at a higher risk of HHT complications postpartum when it's like weeks or months after, or does the risk decrease after a while?
So I would say that, I'm just trying to think of what the question was. Okay, so basically, the postpartum period is defined as 6 weeks. So in general, your pregnancy risks are through pregnancy and then in the 6-week postpartum period, but they will definitely decline after the baby is born. So in the postpartum period, what happens is that all of the hormones kind of go back to their baseline. And so these things, when I discussed about progesterone and causing the veins to be more distensible, et cetera, those kinds of things will decrease over time. And so the risks are going to kind of go back to the baseline risk of pre-pregnancy.
Thank you. Are women with HHT at any increased risk when taking contraceptives?
So no, good question. So women with HHT can definitely take any type of contraception. And again, you would go and discuss with your provider the fact that you have HHT, et cetera, but you basically are able to take any type of contraceptive.
Thank you. Sorry, I'm going rapid pace.
That's okay, no problem.
Are there any infertility problems for women with HHT?
So again, typically no. So if you're having trouble with conception, it's unlikely to be related to the fact that you have HHT. And so really HHT is going to come up as important to treat the, pulmonary AVMs and all that kind of stuff before pregnancy if you can. But in terms of actual conception, there isn't really, HHT doesn't contribute to a cause of infertility. So that would definitely need to be investigated at a fertility clinic.
Thank you. And the last question I have on my end, should pregnant moms with HHT come earlier to the hospital prior to delivery?
So very good question. So again, through your pregnancy, you would be, followed closely by your OB, either at a tertiary care center or elsewhere. And, it would really, it's again, case by case. So are we concerned about any issues arising through delivery? Sometimes, if people are planning a delivery at a tertiary care center, and let's say they live far away, we may consider an induction of labor, that kind of thing. So it really would depend on what your specific situation was. But if you were considered to be kind of low risk from an HHT perspective and planning to deliver, at your local hospital, then you could just follow the regular guidelines for when to come in labor.